Is this the right link?
Yeah.
Hey, Dr. Godwin, how are you?
I'm fine, Kyle. Are you doing a refresher course here, or are you giving the first lecture and I'm not supposed to be on at all today?
No, you're correct. You're giving the first lecture and I'm going to give the second one. We're just hopping on right at the beginning to give some announcements.
Okay.
Don't go anywhere, Dr. Godwin. Did you get your donut? I bought one for you today.
Oh, well,
Are you not here? Should I eat your donut for you?
well, you can, why don't you leave it out? And then I like stale donuts dunked in coffee. I'll get it tomorrow along with used coffee from today.
I'll put it on your desk.
Thank you.
Wait just a few more minutes for names to stop showing up and then we'll get started and then we'll hand it off to you.
Thank you.
All right, the number of new names seems to be slowing down, so we'll go ahead and get started with announcements. Hey, everyone. So the first one is that tonight we have our welcome party at Optimism Brewing. So at 6 p.m. After lecture, be sure to head over there. We'll have pizza, drinks, and yeah, just great company. So we'll get to know everyone, get to know the new R2 class. Should be fun. One thing to please keep in mind is please take a rapid antigen test. We want to make sure that we want to do as much as we can to not create a super spreader event at this party. So yeah, if you could take a rapid antigen test and bring the results with you, that would be great. I think everyone would feel a lot more comfortable. Another thing along those same lines is COVID illness or exposure. So again, if you or a close contact becomes sick or COVID positive, remember to just refer to the guidelines in our UW resources. We've sent that link out. We send it out every week, but it'll be again in this week's newsletter. So just be sure to check that link for the most up-to-date information regarding COVID exposure and sort of what to do. And then another thing to be aware of is, so this week and next week will be obviously via Zoom, but the fourth Thursday of this month, we're going to actually all be in person. So the both lectures, the 3 p.m. and the 4 p.m. lecture on the fourth Thursday of July will be in person at UW. We'll all gather in the Turner Auditorium and do sort of an in-person group-based, case-based sort of hot seat type style. And then Marcus should be sending out an email soon. He'll have more information on how parking is going to work. It's going to be reimbursed through your Husky card. So be on the lookout from an email from Marcus soon. And then the last thing to just sort of keep on your radar is we have a Life After Residency and Fellowship seminar that is going to be on Saturday, August 27th. And registration will open for that in late July. And that's all we've got for the announcements. So Dr. Godwin, it's all yours.
Thanks, Kyle.
So I hope people can see a screen here that hints at fungal infection as our topic for today.
Yes, we can.
Okay. So I want to emphasize that fungal infection has really two faces that we see at UW. One is the fungal infections that go with our immune compromised populations. This is our solid organ transplant people, people with lung or kidney or liver transplants are susceptible to fungal infections at a higher than normal rate. And then our bone marrow transplant population is even more susceptible. So we see fungal infections mostly in the context of immune compromise, but there are endemic fungal infections in the United States, and we will discuss those. And we have one that's a regional specialty, this Cryptococcus gaddii, which likes the Pacific Northwest most of all. So this is the goal of this talk for the next half hour or so. I want to show the many manifestations of Aspergillus infection because we see a lot of those, and some of them are not really infection, but they're presence of Aspergillus creating an allergic response, for instance. So there are non-invasive forms of Aspergillus. Then we see the aggressive forms, the invasive forms in solid organ transplants and even more in stem cell transplants or other neutropenic chemotherapy patients. This may be a bit of a surprise, but Aspergillus can be disseminated in marijuana smoke. So a lot of our patients smoke marijuana. Sick patients tend to do it at a higher than normal rate. Normal people who are not immune compromised or have chronic illness also smoke marijuana, but we can see airways dissemination of marijuana from marijuana smoking. I'll show you some examples of that. We'll talk about the regional endemic mycoses, and the map on your right shows the overlapping geographic locations of the four infections that we'll talk about: histoplasmosis, cocci, blastomycosis, and cryptococcosis. So the green is Cryptococcus gaddii, and that is this Northwest specialty that overlaps into California and goes up into Canada. Cocci is this southwestern distribution. That's a dry desert sorts of environments. And then we have blastomycosis overlapping with histoplasmosis in the Midwest. And we'll take it from there. So I want to point out disseminated histo as an AIDS defining infection. So you may see a miliary pattern of histoplasmosis. If you do, strongly suspect that there's an immune compromise going on, and it's often, it turns out to be HIV/AIDS. And we will discuss our regional specialty Cryptococcus gaddii, which is somewhat more aggressive than the regular Cryptococcus neoformans that we were familiar with before. We'll start with aspergillus, and we'll start with some non-invasive manifestations. So non-invasive aspergillosis is most commonly a mycetoma, that is a fungus ball in a pre-existing cavity. So the cavity could be left over from TB or sarcoid, or could be a bulla, some other cavity. And then basically aspergillus just starts living in that cavity rent-free. It's not invading the wall, but it can incite an allergic response by its contact with the wall. So there may be an allergic response to that would cause some wheezing, cause eosinophilia, and so forth. So mycetoma is in a pre-existing cavity. Allergic bronchopulmonary aspergillosis is the result of aspergillus being in a mucus plug and inciting, again, an inflammatory response with eosinophilia, cough, wheezing, and things like that. So if aspergillus is present in the mucus plug, then there may be a host response to that. That would be allergic bronchopulmonary aspergillosis. Typically, there is a pre-existing bronchial abnormality, and it's often asthma or cystic fibrosis. In our population, it tends to be cystic fibrosis because we have a number of adult cystics. Then there's invasive aspergillosis, and if you are compromised by being on corticosteroids, by having AIDS, or from chemotherapy, that's the setting for invasive aspergillosis. Solid organ transplantation, it's often asymptomatic and incidental finding on regular screening radiographs when these patients come to clinic for follow-up. But it's even more aggressive in stem cell transplantation because of the profound neutropenia. So we see in solid organ transplantation, often people are not symptomatic, but in stem cell transplantation, they are very symptomatic from even more rapidly invading infection. We'll start with mycetoma in a cavity from remote TB. So there was a cavity in the left apex here, and you can see that the cavity is occupied by this big mass here, which turns out to be a fungus ball. So here's the fungus ball in that cavity, and there is a sliver of air around it. This is the monod sign. Please don't confuse it with the air crescent sign, which we'll talk about later with invasive aspergillus. So when the fungus ball fills the cavity and leaves a sliver of air, don't call that the air crescent sign, it is the monod sign. So this is non-invasive aspergillus, it's just passively living in this cavity. There's probably a bulla or cavity on the other side as well. You can see that there is right lung abnormality as well. So we have this big fungus ball living up there. And if you move the patient around, the fungus ball typically tumbles around. So the differential diagnosis for a mass in a cavity is fungus ball like this, mycetoma. But other considerations, if the person had hemoptysis, it might be a blood clot. So that can do it. Sometimes it's tumor. So there are other considerations for something that occupies a cavity, but mycetoma is the most fun. Here's another example. This person had had a left lung transplant because of pulmonary fibrosis. So in the native right lung, we see a lot of fibrosis. The transplanted left lung is relatively clear by comparison. Because of the fibrosis, there's traction on the mediastinum and the trachea is going in this direction. It's hard to see on the radiograph, but on CT, you can see that there is a mycetoma in one of these cavities here that's a result of fibrosis. So we have a crescent of air around it. Let's call it a sliver of air so I don't commit the error I'm cautioning you guys against. This is the monod sign, not the air crescent sign. So the sliver of gas around the fungus ball is the monod sign, not air crescent. And a very similar sort of thing is allergic bronchopulmonary aspergillosis. In this case, the cavity is really the dilated bronchus, and it fills with a mucus plug. The mucus plug can contain aspergillus. We were always breathing in aspergillus. It's a ubiquitous organism. We're breathing it in, and if you have an abnormal bronchus or you have a cavity, it can land there and start to grow there. So in this setting, it grows in the mucus plug. It's a great culture medium in these dilated bronchi. And in doing so, it contributes to bronchial inflammation and even more bronchiectasis. So once this process starts, then it tends to be ongoing and it feeds on itself. So you get more and more bronchiectasis. It's typically a localized right upper lobe bronchiectasis, second most common, left upper lobe. Unlike other bronchiectases that we see from immune deficiency or ciliary dysmotility or cystic fibrosis, it's localized and central. Now, there can be other manifestations besides the mucus plug, this finger and glove pattern that we're seeing so nicely here. You may see pneumonia around it. You may see an eosinophilic pneumonia around it because this is often contributing some allergic symptoms, some irritation, and a eosinophilic response to it. So you may have eosinophilia, cough, elevated IgEs, and so forth. It can lead to collapse. And so we have collapse of the right upper lobe. This is all the same patient at different times. When the mucus clubs are coughed out, you can be left behind with this central bronchiectasis. Now, the treatment for this is not to give antifungals because those would not be effective in cleaning out this infection, but it is to give corticosteroids to quell the inflammation and allow the mucus plugs to shrink and be coughed out and clear. So that's the treatment, is really just reduce the inflammation. You can't really sterilize these bronchi and prevent the aspergillus from growing again. Rarely they will treat this with antifungals, but generally it's just with anti-inflammatory corticosteroids. So here's what it looks like on CT. It's a fairly localized, selectively right upper lobe bronchiectasis in this case. Here it is with the mucus plugs gone. We are left with these empty dilated bronchi, and lower down, same thing. So allergic bronchopulmonary aspergillosis. The patient typically presents with a worsening of symptoms of asthma or a worsening of the symptoms of cystic fibrosis. And it turns out that they have this fungus, which is causing an allergic response and more bronchoconstriction and more wheezing and so forth. This is what invasive aspergillosis looks like in a solid organ transplant. In this case, a heart transplant patient. This person came in for a routine 1 yearly visit and turned out to have this asymptomatic nodule floating around up here. Here's the previous radiograph for comparison when the nodule wasn't there. Here's what it looks like on CT. It's got a nice little air bronchogram. It doesn't look cavitary, doesn't look very aggressive. It's a fairly small lesion. And this is what invasive aspergillus looks like in a solid organ transplant person. These people are slightly immune compromised, nowhere near as immune compromised as a neutropenic chemotherapy or stem cell transplant patient. And so they contain the fungus fairly well. It doesn't grow very fast. And these can be treated then with some antifungals. It's not going to be that aggressive. I mean, you wouldn't want to have it, but it's not as bad as having it if you had a solid organ transplant, sorry, a stem cell transplant. Okay, here's what it looks like in a chemotherapy patient who's profoundly neutropenic. And it's these ill-defined blobs. So part of invasive aspergillosis in this neutropenic setting is that you have fuzzy boundaries because this stuff is really going into tissue, and it's also, there's some bleeding around it and so forth. So unlike the well-defined nodule that we saw before, you tend to have fuzzy nodules early on. So there's one on the left here. There's another one here. Again, they're hard to see because they're fuzzy. There's an accompanying pleural effusion down here. So with neutropenia, you have a much more aggressive invasive aspergillosis, and it has fuzzy margins. So on CT, this CT is around the time of that chest radiograph with fuzzy nodules. You see that this spiculated kind of ragged looking lesion up here has a surrounding halo. So there's a ground glass halo around it. This is attributed to hemorrhage caused by the angioinvasion here and the infarction of lung. We also see the halo sign in these other ragged looking lesions. So with invasive aspergillosis in neutropenic patients, expect fuzzy boundaries. You'll often have the halo sign early. So this is the early sign of invasive aspergillosis in these neutropenic patients. Then with time, we go on to the air crescent sign. So 8 days later, we now have the air crescent sign. So this infarcted nodule here has now shrunk, and it has freed up this little space here. This little air crescent appears as the central contents kind of shrink down. And here we have another air crescent going on down here. So in the air crescent sign, we have a fungal infarct that is shrinking, and that causes the air crescent sign. So the air crescent sign goes with invasive aspergillus, and it usually occurs when the host is recovering some white counts, when the host is able to mount a response and cause some cavitation, some shrinkage of the lesion, because the white cells are now going in there and working. Now that's the story that everybody tells. So it's supposed to be, you're supposed to see the air crescent sign as the host responds. But perhaps it's just the evolution of an infarct that's causing this shrinkage and cavitation and the air crescent sign. And maybe that just coincidentally is timed with the person's recovering some of the white count. So is it really the white count returning that does it, or is it just the timing, the coincidental timing that causes that? Either way, the first answer is what the boards are going to expect you to say. So repeat the mantra. Okay, now here's another way to get aspergillus, and that is to smoke marijuana. So this person has this nice clear lungs here on a baseline radiograph, and then we have this very busy look here with diffuse lung disease. It's really hard to characterize, but everywhere you look, there are extra little things going on here, maybe extra little white lines. It's really hard to describe, but it's very busy looking. So this person is also somewhat short of breath. And here's what it looks like on CT. And we have this really diffuse lung disease that seems to be sort of centered maybe in the centers of lobules, a little peripheral sparing at the edges of the lobule here. But everywhere you look, there are these little dots that are probably mostly centrilobular. And these are inflamed small airways from aspergillosis in these small airways. So this person has inhaled aspergillus in the marijuana smoke and has this diffuse bronchiolitis pattern here of these small little dots. So this is marijuana delivered aspergillosis to the upper lungs. Now, this is really a florid case. You'll see cases where it's less apparent. It tends to be an upper lung distribution of small airway shadows as a result of marijuana smoking. So marijuana can survive the high temperatures, at least some marijuana survives the high temperatures that go with burning and creating the smoke. Now, besides aspergillus, there are other fungi that can hitch a ride in marijuana. And this is an example of Trichoderma citronoviridae that causes very nice halo signs here. So we've delivered a number of nodules in the upper lungs here with a very nice halo sign. It looks just like invasive aspergillosis, but in this case, it's Trichoderma, it's not aspergillus. So fuzzy nodules on radiographs, halo sign, ragged spiculated margins on CT, looks just like invasive aspergillus. This was Trichoderma citronoviridae, which can hitch a ride on marijuana plants. Okay, let's go on to our regional specialty Cryptococcus, and we'll start first with the non-regional version, Cryptococcus neoformans. We'll get to Gaddii in a minute. So this is a cause of lung nodules, and I did a study years ago at Duke, and we found that 50% of the cases of Cryptococcus that we had there were in compromised hosts, and the rest were in normal hosts. So it's possible to acquire Cryptococcus neoformans even if you're a normal host, and you can be outside and pick it up from soil or something like that if you're in a dusty environment. One case I remember was a telephone linesman. So this is a person who climbed telephone poles out in the country. So he was exposed to a lot of stuff in the environment. So you can see a slowly growing lung nodule if you're a competent host, and it may be mistaken for tumor at the rate it grows very slowly maybe over months or years. So that's one form, particularly in a non-compromised immune competent host. And then we'll talk about Gaddii, which is this relatively newly described disease in our area. So here's a diabetic patient. If you do have immune compromise, such as diabetes or COPD, you have a higher rate of getting most fungal infections. So this diabetic patient has a nodule in his left lower lobe. He's got a couple of other smaller nodules along airways slightly higher up. And it's really hard to see on the radiograph. It's mostly hiding behind the heart. So this was a person with a low degree of immune compromise, diabetes in this case. And then here is a fellow who presented dramatically to Harborview and UW. He was in town, he was in Seattle because he was scheduled to go on a cruise, a honeymoon cruise the next day. 25 years old, immune competent person who has this big nodule here on the right lung base, very well defined. And this is the kind of indolent pattern of Cryptococcus that you see was a very well-defined nodule. It looks like a tumor nodule, and these things can grow slowly. So presumably this immune competent person has had this for some time. This is probably a slow-growing thing. However, the reason he had a seizure was because he also had it in his brain, and so we have this big abscess in his brain. It turns out he had headaches and syncope 6 months before. This has been going on for a while. And they recovered Cryptococcus. This was before people were alert to Gaddii, and this is probably neoformans. He was from the Bay Area. I don't think he'd had previous exposure in the Northwest that would have brought the question of Gaddii up. Now, Cryptococcus gaddii is our regional specialty. This is something that you find in soil and associated with certain trees. It's been around for a long time, mostly in Australia and Papua New Guinea, but really throughout the world. And then beginning in 1999, it began to be reported in British Columbia. It's a different strain, not quite the same species or strain. Probably strain is a better term. So there have been several hundred cases starting in 1999, mostly in Oregon and Washington, and in addition to BC, but it does overlap down into California and even in the Southeast. So it's in other states too, but most of the cases here are here on the West Coast. Mostly affects lung and brain. Now the British Columbia strain that was first identified, the Northwest, is mostly lung disease, but the Australian Papua New Guinea is mostly meningitis. And this has a very long incubation period. So this six to 7 months can really throw the diagnosis off, because a person might have had an exposure in the summer by visiting British Columbia or Seattle, and then goes home and 6 or 7 months later gets sick. People are not thinking about that remote exposure 6 months before in the Northwest. The risk factors are being in the wrong area, having immune compromise, cigarette smoking, being old, that means like 50 or more, that's really ancient. And Gaddii is more likely than neoformans to attack a normal host. So we see this in people who don't have any identifiable immune compromise. It has a reasonable mortality rate. That's not good. And as I said before, it's mostly lung infection around here, but it's mostly meningitis, and it can be treated with fluconazole. So here is the CDC's little summary of Cryptococcus gaddii. It exists in a hyphal form in soil or on tree bark and things like that. You inhale these little spores. They form a yeast form in the lungs, which means, and it's encapsulated with this big capsule. This thick capsule helps protect it, and it's because of the capsule that it's called Cryptococcus, meaning it's hidden or it's tucked away in this big capsule, which sort of prevents the host from responding effectively to it. And then from the lung, it can get into the bloodstream, it can disseminate, for instance, to the brain. So typically the CNS is the site of dissemination. Here's what it looks like in our population. This is a previously healthy person, so no immune compromise, developed headache, cough, and night sweats, has this nice lung nodule here, has another lesion here on the other side as well. Fairly well-defined nodule, had been to Vancouver and Whistler in British Columbia. here's what it looks like on CT. It looks like probably a necrotic nodule out against the edge of the lung. This nodule might have a little bit of necrosis in it too, fairly well-defined nodules. So maybe it's because this is a host with intact immunity that we have the thing confined to a fairly well-defined nodule. Maybe that goes with being confined. And there was nothing in the CNS. So just, headache is probably a sign of generalized inflammation. It doesn't have to be from CNS involvement. So most of the patients we have, even without CNS involvement, do have a headache with this. Now here's a person who is older, has myelodysplasia, which makes this person more immune compromised, and chronic renal failure. That doesn't help, and has C. gattii in the sputum. Negative CSF antigen studies, has this big ragged looking pneumonia that's up front here. So left upper lobe tucked up against the anterior chest wall there. So a big necrotic pneumonia here with nice air bronchograms. Has another lesion on the other side here, a nodule on the other side, has an accompanying pleural effusion, and probably has at least modest lymphadenopathy here in the mediastinum. So this is Cryptococcus as a pneumonia, a big pneumonia. Here's a person who has a dilated cardiomyopathy. Is from Vancouver, Washington. Went to Kansas, Georgia, and Texas and got sick there, had a mild fever. Of course, they were not suspecting Cryptococcus gattii. They treated the person for community-acquired pneumonia. Person was not on any immune-compromising drugs, does have a dilated cardiomyopathy, a big heart, and has a ton of lymphadenopathy here. So right paratracheal lymphadenopathy, right hilar lymphadenopathy. And on CT, we found a small nodule out here, and then massive lymphadenopathy centrally, and subcoronal lymphadenopathy down here. So Cryptococcus grew out of the blood in this person. There was no identified immune compromise. So if you're going to come down with gattii, you should come down in the Northwest where people are going to be considering it as a possibility. But if you do it in Texas, they probably don't have gattii on their map. So let me just summarize these three cases to show you the spectrum that we've seen in Cryptococcus gattii: nodules, pneumonia, and in this case, a small nodule but massive lymphadenopathy. Let's go on to coccidioidomycosis, which is valley fever, named for the Central Valley in California. It overlaps through Nevada and Utah, Arizona, New Mexico, Texas, and into the Sonora Desert of northern Mexico. So this is inhaled from spores in these dry desert environments. So cocci lives as these hyphae in the environment, and then these things break up, and these are the infectious little things that are carried in the wind. So in California, there is this reversal of the normal airflow in the wind. So normally you have breezes coming off the Pacific and heading east, but in the Santa Ana wind conditions in Southern California, I think the name is also applied in Northern California, the wind can reverse and you get this desert winds in September typically that cause heat waves in San Francisco by blowing west from these desert. And when I was in San Francisco back in my training era, there was an epidemic of cocci in San Francisco caused by one of these reversals of the wind. So the spores were carried from the desert into San Francisco, and a number of people came down with cocci in an environment where you don't expect to see it arising. So windstorms can kick this stuff up. So there was a group of University of Washington archaeology or geology students who were doing some field work in Arizona, a number of whom got cocci because they were there and it got windy, and so the spores were kicked up by the wind and inhaled by a number of them. Once it gets into the lung, it forms these spherules, and then these are packed with these tiny little infectious endospores and stuff like that. Then they can create new spherules and so forth. So cocci is now in Washington state. So if you go back to the map, notice that there's a little patch of cocci here in eastern Washington, because parts of Eastern Washington are very dry, and they resemble the dry desert valleys in California. And so you can get cocci in Eastern Washington as well. So cocci, there was an acceleration, it's probably weather related here. There was a big spike in cases that peaked in 2011 and then has fallen off since. So this is probably weather related or some wind condition related. So it's called valley fever because of its affecting people in the Central Valley in California. There are certain people who are more susceptible, and the outstanding group is really Filipinos. So Filipinos have a much harder time with cocci, but also Blacks, older people with people with compromised immune systems, pregnant women, and diabetics are also susceptible. So it's in Eastern Washington as well. We do see it. We do see some cases that were acquired here. We see many more cases probably of people who are vacationing or spend certain times, parts of the year in Arizona, for instance, in vacation homes or to escape the winter gloom. So here's what it looks like typically. It's famous for causing thin-walled cavities. And the cavities start out with thicker walls. They grow over time and the wall tends to thin out with time. But here's one with sort of medium thickness or medium thinness of the wall that Tasneem Lalani, one of our former faculty members, sent. So we have a few of these cavities around. It seems to like the mid-lungs. These cavities can last a long time. So here's 2011 with a small nodule just beginning cavitation. And then we have a slightly thick walled cavity with maybe a little fluid level here in 2014. Here it is on CT from 2011 to 2016, small nodule cavitating, getting larger, still having a medium thick wall, even larger still with a thick wall. Often these will then evolve into thin walls and they'll just smolder for years. So this is an often smoldering infection that can go on a long time. Here's a nodular form with lots of lung nodules, probably hematogenous dissemination. So these probably grew up from being miliary, really small nodules, to these 3 and 4 and 5 millimeter nodules. So this is probably blood-borne infection. It can also spread through the airway. The uniformity here, I think, is better for at least a component of hematogenous dissemination. And then here's a person with massive mediastinal lymphadenopathy, night sweats, cough, weight loss, some left upper lung disease up here. This seems to be along airways. I think if this case came into Harvard U, you would say this looks like tuberculosis with this airways location of upper lung infection, and then necrotic lymphadenopathy, massive necrotic lymphadenopathy. So low attenuation lymphadenopathy indicates caseous necrosis in TB, but you can also see it, as in this case, with cocci. Also, this person has back pain and has bone infection. So a vertebral body is infected down here and there's surrounding tissue infection around it. This looks just like TB. So these cases can masquerade as TB. I've seen a number of cases mistaken for TB. And these necrotic nodes have formed a fistula, which you can see here to the esophagus. So necrotic nodes, in this case, have fistulized. And here it is on an esophagram done by Dr. Rohrman. You can see contrast getting out of the esophagus into this necrotic node up here. You see it up here as well. So dissemination, in this case, to nodes in the mediastinum. Necrosis, fistulization looks just like TB. Histoplasmosis is probably the most common of the endemic fungi. So most people who live in the Midwest along the Mississippi and Ohio River valleys have been exposed to histo, and there are a number of calcified granulomas in people that are really just incidental finding, to the point that a lot of radiologists in that area don't even comment on them because they're so common. So typically the manifestation of histo is an incidental finding of a calcified granuloma or two in a person who's not symptomatic at that time, or might have had mild symptoms in the past or not even been aware of being infected. So it's mostly centered in the Midwest along these river valleys. Does overlap though even into California. Again, this is inhaled and it sets up in the lung, and from the lung it gets into lymph nodes and it can disseminate from there. So you'll often see dissemination, for instance, to the spleen. So calcifications in the spleen are very common in histo. In this country, they are uncommon in TB or other fungal infections. So calcifications in the spleen really point strongly to histo in this country. So this is in the soil. It is particularly in soil that has bird droppings or bat droppings. So in parts of the country, such as North Carolina, there's a lot of poultry farming, and poultry farmers are susceptible to histo because of that proclivity of the fungus to grow in bird droppings. And even in Seattle, there was renovation of an old building downtown. I think it was the train station. There were some pigeon droppings, and somebody got histo from pigeon droppings. So bird droppings are a favorite thing for histo, even in non-endemic areas. Now, another consideration, another flying animal to consider is bats. And so one of our pulmonologists was slightly immune compromised because he was on some treatment for sarcoidosis. He visited this cave in the Midwest that is famous for having bats. So it's some national park that has these caves. He was in that cave. He came down with disseminated histoplasmosis from exposure to the histo in the bat guano, the bat droppings. And he was mildly immune compromised, which is why it disseminated. So risks are having a weakened immune system, having had an organ transplant, being on corticosteroids, and people being old, like over 55. And it says infants over 55. I think it's really infants and then separately adults over 55. So I don't know very many infants over 55, but they would be at higher risk. So the usual finding is just a calcified lung nodule or calcified lymph nodes. The lymph node calcifications that you see are going to be more, you're going to see more of them. They're going to be more robust. The granulomas are going to be bigger than what you'll see in TB in most cases. Granulomas in spleen, again, pretty specific for histo. Disseminated histo is an AIDS defining condition. I'll show you an example of that. Now, these calcified lymph nodes can cause problems. They can compress or erode into bronchi. That's called broncholithiasis. And then there is an inflammatory condition that can be triggered by histo, even after the histo is no longer alive. Just the presence of the antigen can contribute to this flagrant or florid fibrotic response in the mediastinum that can end up pinching off the superior vena cava or pulmonary artery or veins or airway. So that's called fibrosing mediastinitis. You will not find histo in that biopsy material, but you're seeing the inflammatory and fibrotic response to histoantigen. So here's the typical finding from histo: a calcified granuloma, usually well-defined, calcified lymph nodes here in the left hilum, and a smaller focus out here. So this is classic findings of histo. Generally, you're not going to see this much calcification in lymph nodes from TB, at least in this country. This person has these ginormous histogranulomas all over the place. This is a case from Thurman Gillespie, former trauma radiologist at Harborview in years past. And he sent me this case from from Everett. So we have these giant histogranulomas in the lung, and we've got a lot of mediastinal and hilar lymph node enlargement too with calcification. And I'm sure that if you look down here, you can even see some in the spleen. So it panned out. Now this is miliary histo, which can be an AIDS defining condition. So this 21-year-old, recently married, recently immigrated, had unprotected sex with prostitutes, very low CD4 count, huge viral load. This was AIDS defining miliary dissemination of histoplasmosis. So tiny nodules all over the place, really a miliary pattern, bloodborne histo. And here's an example of reactivation of histo, just the way TB can reactivate if you become immune compromised by getting old or by developing AIDS. You can develop primary TB all over again. So this person had a pre-existing nodule that sort of grew out of the nodule. So the histo organisms reactivated since the immune response was off and caused this pneumonia around this necrotic thing here. So this is reactivation of histo because of HIV. Let me show you fibrosing mediastinitis, this inflammatory fibrotic response in the mediastinum, usually long after histo is passed. And so we have this inflammatory tissue here that is pinching off the main part of the right pulmonary artery. So here's the artery really ending in this fibrotic mass here. Here are some calcified lymph nodes from this histoplasmosis. Typically there are calcified lymph nodes, but this is a separate response, really a fibrotic response. And we see a lot of fibrosis. Now this can become even more extensive than this. This is actually a fibrosing hylitis, which is localized to the hilum, but you can get more central involvement. And the most common thing that gets pinched off is the superior vena cava. So that's most common, and that would be a deeper thing. So this is fibrosing mediastinitis, or in this case, maybe fibrosing hylitis, more localized, same idea. Here's what it looks like on the pulmonary angiogram. You can see this tapering here caused by this scarring around the pulmonary artery. And they placed a stent and they opened it up and restored better blood flow down there. And on this perfusion scan, you can see that there's very little perfusion going on down here before they treated this. You can see the paucity of vessels on CT because they were pinched off by the fibrosing mediastinitis hylitis, and stuff is being diverted to the anterior parts, and because that circulation is more open. And our last regional fungus is blastomycosis, which is particularly prevalent in Wisconsin. So this is acquired usually from outdoors, from moldy leaves in particular. It's often called riparian, meaning it occurs along streams. So it likes this kind of wet environment. So it's muddy or wet leaves and stuff like that. And one of our residents, former residents, was from Wisconsin, and her dog died of blastomycosis. And then your dog could bring it home to you. So you might pick it up from your dog. So your dog might be in these environments where he picks up the organism and then transmits it to you or other people who handle the dog. So these hyphae here can bud and stuff like that. The hyphae produce spores. You inhale the spores. Inside the host, it transforms into a yeast the way a number of these organisms that we discussed do. And from there, it can colonize the lungs. It can get into the bloodstream. It likes to go to skin. It can even go to CNS. Skin is the second most common site. So it's inhaled, or sometimes you can acquire it directly from skin. So it's in soil, particularly with decomposing wood or leaves. Exposure is the big problem. Wisconsin has the highest rate. A number of the cases I'm going to show you are from Jeff Caney, who's one of our former residents, who's now a chest radiologist at University of Wisconsin. So you breathe this in, or you can get it through the skin, or a lot of the skin infections are actually derived from the lung, getting into the bloodstream and then out to the skin. So we can direct inoculation or hematogenous dissemination to skin. It has a fairly short incubation period, 3 weeks to 3 months. A lot of these cases will show up in the fall. People are out walking in the fall, or they got it in the summer and it shows up later on. So fever, cough, night sweats, all those systemic symptoms, it can be quite severe. It is often a pneumonia. So it seems to like to be a pneumonia more often than it likes to be a nodule. And it's often mistaken then for a community-acquired pneumonia. It doesn't respond that well to antibiotics. And so the diagnosis and treatment can be delayed. So it can be a necrotic pneumonia that's fairly fierce. Now here's a local case of blasto. This was a Harborview patient. He was a 29-year-old who like to lead river rafting trips in North Carolina, Tennessee, and in Michigan. And he has a cavitary nodule in his left apex. Now, normally, if we saw a thin-walled nodule like this, one of the first questions would be, is this cocci? This really looks like somebody who traveled in Arizona or California and picked up coccidioidomycosis. This turns out to be blasto. And there's some infection on the other side too. Here's a nodule with cavitation. This is a fairly discrete nodule. This is from Jeff Caney in Wisconsin. This person also had quite a bit of lymphadenopathy. Jeff points out that generally lymphadenopathy is pretty modest in blasto, and pleural effusion is usually pretty modest. So you don't tend to see a lot of lymphadenopathy in this condition. I think you probably see more lymphadenopathy with cocci than you do with blasto. And here's a case of a necrotic pneumonia. This one is one of our cases. The man himself was from Chicago area, so he was in that endemic area. He's a Somali man. He was working in Alaska when he got sick, and he was transferred to Harborview. He has this big bulging pneumonia with necrosis up here. So this looks like a necrotic pneumonia. If you told me this was staph MRSA, I would say that's just fine. It's a necrotic pneumonia, but it's blasto. And Jeff Caney emphasizes that a number of these cases do look like a necrotic pyogenic infection. This person does have some lymphadenopathy and does have pleural effusion, but fairly modest effusion given the degree of pneumonia here. So this was pneumonia caused by blasto. Who would have thunk? Here's a bulging pneumonia, again, a necrotic pneumonia, courtesy of Jeff Caney from Wisconsin. And this was a 52-year-old man who was compromised by having had a liver transplant. There's also infection on the other side too, just not as bad. So it often looks like a pneumonia. It can be a necrotic pneumonia. Here's frank necrosis with a hole in it. And here is a local case, a 37-year-old who is working with fertilizer from pheasant droppings, so bird droppings. He has this extensive pneumonia in the right lung base, but he's got stuff on the other side as well. And here are the forms. I said this was a local case. I was wrong. This is one of Jeff Caney's case. Here is the here are these yeast forms, and they're probably budding. And then here's a 10-year-old boy with this pneumonia from blasto and also knee involvement. So he's got this infection of his bone, and you can see the effusion in the knee and so forth on MRI. So it likes to go to bone. It likes to go to skin. This woman has a pneumonia from blasto and has this ugly looking skin lesion. She liked to hike in northern Wisconsin. It made her healthy, but in this case, she got blasto. So stay indoors and just limit your exposure to the remote control. So let me give you a little just take-home summary of our fungal experience today. About aspergillus, it's ubiquitous, it's all over the place. We're always breathing it in, and it takes hold if you have abnormal bronchi or you have a cavity for it to live in, or if you're immune compromised. Marijuana smoking is one way to get fungal infection, particularly aspergillus, but other fungi as well. Cryptococcus gattii is our Northwest specialty. It can be a smooth nodule, symptomatic patient with fever, headache, cough. You know, it's got to be on the list for a lung nodule in this area. Blasto is often mistaken for bacterial pneumonia. Geography matters. The problem with geography is people don't stay put, they travel around. They can bring it home, they can develop it 6 months later. And so you're not suspecting it because their exposure in an exotic location like the Northwest was 6 months ago. So be alert to the possibility of long latency. Okay, so let me ask you a couple of questions here. The cavitation, the air crescent sign in invasive aspergillosis most likely indicates which one of the following. So can people shout out an answer here? Is it A, worsening infection, B, host response to infection, C, immune system dysfunction, D, secondary infection? What do you think? Anybody?
B as in bronchi.
B.
Okay, good. So B is the correct answer. it is attributed to the host response beginning to cause the lesion to become contained and to shrink and evolve and so forth. So whether that's true or not, that's what everybody says. So that's what you should say too. Okay, next question. Which clinical bit of information is most effective in predicting the species of the fungal pathogen? So is it age, fever, consolidation, or location and travel? Anybody?
B.
B.
B as in bog or D as in dog?
Dog.
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 Okay, absolutely right. So it's dog. It's location and travel. So it's where you've been in predicting which endemic mycosis you might have. Okay, we made it. So now you know all about fungus, and Kyle is, I think, getting ready for your next hour. Thank you very much for your attention.
I had a quick question, Dr. Godwin, if you've got
Yeah.
time.
Yes.
You mentioned smoking as being like a fungus issue with it. Any issues with vaping and like the vaping oils, or maybe the heat would deactivate any of the fungus in there?
So the vaping oils are probably not contaminated with fungus. But there is another condition associated with vaping. So EVALE is the vaping related lung disease, especially the marijuana oils seem to cause this reaction that makes people quite sick. So marijuana oil smoking vaping is a different condition, but it's not really fungus that's causing it. It's the compounds, or it's the marijuana oil itself that elicit this response in the lungs and alveolar damage, and often an NSIP pattern.
Okay, thank you.
So don't vape, don't smoke, and don't vape. That's the way to be safe. Okay. Any other questions? Thanks, everyone.
Thank you.
Thank you.
Thank you.
Hey, everyone. Did Dr. Godwin finish fairly recently? I was just gonna see if you guys, okay, cool. Do you guys need like a bit of a break?
Let's keep her going.
I like it. Let's do it. All right, let me share my screen here. Okay. All right, so I know Dr. Godwin just talked to you all about fungal infections. So now we're sort of going to do a brief overview of all the other lung infections. First off, I want to acknowledge Dr. Pipavath. He's been awesome. He shared all of his awesome cases he's gathered over his decades of doing this. And so I'm very thankful for him for sharing those with me so that I can share them with you. All right, so this is a nice sort of sentence that sums up pulmonary imaging from the radiology perspective. So no radiologic pattern provides a specific etiologic diagnosis. However, the pattern and the clinical and epidemiologic information can help you narrow down that your diagnostic considerations. And in the meantime, they're trying to gather more specific microbiologic data. So we really help out the clinicians in that interim period when they are trying to come up with a specific microbiologic diagnosis to have more targeted therapy. So this is just sort of another recap of that. So we use the imaging pattern and the patient's clinical clues. And the ultimate goal is to narrow down the differential diagnosis for the clinicians. All right, so what do we use to image pneumonia? So the two common modalities that we'll use are chest radiography and chest CT. So the chest radiograph is going to be sort of your bread and butter when it comes to imaging of pneumonia. It's going to be your screening tool. So if a patient comes in in the urgent care or the ED or even just the outpatient clinic, very common for them to have any sort of respiratory symptoms and get a chest radiograph. And this is just a basic screening tool to see, is there a consolidation or a pneumonia? You can also use the radiograph to look for alternative diagnoses to pneumonia. You can use it to assess for the disease extent, any sort of complications like an empyema or a pneumothorax. And it's really, really helpful to monitor the response to therapy. So oftentimes you'll have an older person come in with the classic symptoms of pneumonia. You'll see a consolidation on a chest radiograph, and then they'll get a course of antibiotics. And so given their age and that they're also at risk for primary lung cancer, you want to have them come back in like 6 to 8 weeks to ensure that the consolidation has resolved following the course of antibiotics. So when do we do CT? We use CT anytime that the pneumonia looks more complicated than we expect, and it's helpful to better characterize the abnormalities that aren't as well seen on a chest radiograph. We also use it to assess for complications. So for things like a pneumothorax or an empyema, you can use a chest CT to get a little bit more information and a little bit more detail. And it's also important in patients who are immunocompromised. A chest CT will help you be more sensitive and help you diagnose infection early, which is really important in these patients so they can get started on treatment sooner rather than later, because infections in this population can really explode quickly. Okay, so these are the main organism types that we're going to be talking about. I've sort of grouped them because, as we'll see, they sort of share certain imaging aspects that help you differentiate one group from the other. So on the left, we have bacterial, microbacterial, and fungal. Again, I won't go too deep into the fungal because you just got that from Dr. Godwin. And on the right, we have atypical organisms. So these are going to be your atypical bacteria like Mycoplasma pneumoniae, your viruses, and then Pneumocystis jirovecii also is in this group. All right, and then here are the 4 sort of big imaging patterns that we try and lump the findings into, because they can help us narrow down our differential based on if we see one of these 4. So we'll sort of step through each of these one by one and try and see how they can help us narrow our differential diagnosis. So we'll start with consolidation. And this is actually going to get us to our first case. So this is a 65-year-old female with fever and cough. And the question is, what is the most likely organism causing this patient's pneumonia? So I actually have Zoom polls. Oh, wait. I think so. Hey, Marcus, are you on the call by any chance?
I am. I asked Ahmed if he had set you up as host or co-host to run the polls. I have not heard back from him.
Oh, gotcha. Okay. Well,
Did you
that's
guys
all
work
right. We can
together
make...
ahead of time?
No, I did not. That's okay. We can
Okay.
make do. Let's see. Just get out of that. Okay. In the meantime, we'll make do. So what is the most likely organism causing this patient's pneumonia? That is going to be, I'll let you sort of answer in your head, but we can go forward. So it's going to be a bacterial pneumonia. All right. So this is going to be the classic example of lobar pneumonia. So what lobar pneumonia is it's a term you'll hear a lot, and it's the most common type of pneumonia that you'll see on like a chest radiograph. This originates in the alveolar spaces, and it spreads via the pores of Kohn. And that distinction will be important later on when we talk about other types of pneumonia. So it starts in the alveolar spaces themselves, and then it develops into a consolidation by spreading via the pores of Kohn. An important thing about this pneumonia is that it's usually marginated by the fissures. And so as you can see here, the consolidation is filling up this right middle lobe, and it's bounded nice and sharply by the minor fissure. Air bronchograms are common in lobar pneumonia. And then far and away, the most common entity causing this is going to be bacterial infections. So strep pneumo is the classic example of this, and Klebsiella is also a common bacterial cause of lobar pneumonia. All right, this is another case of lobar pneumonia, and this shows nicely that you see the air bronchograms. And that's because since it does originate in the alveolar spaces and spread via the pores of Kohn, it doesn't actually fill the central airways. And so the central airways remain aerated, and that's what gives you these air bronchograms. And these are also just air bronchograms again in a patient with lobar pneumonia, but this is what they look like on CT. So the surrounding lung is consolidated, and the bronchi that run through it, the more central bronchi, remain aerated, because that's not how this particular type of pneumonia spreads. Okay, that brings us to our next case. So this is a 65-year-old male with alcohol use disorder. He presents with fever and cough. So what radiologic sign are we demonstrating here? Is this the halo sign, the bulging fissure sign, the incomplete border sign, or the deep sulcus sign? All right, give you some time to think. So this is the bulging fissure sign. So basically what this means is that this is a consolidation that created exudate that was so exuberant that it basically expands the lung beyond what a normal air-filled lung would be. And because lobar pneumonia is bounded by the fissures, when it expands, in these cases, it will actually make the fissure bulge out. And there's a specific entity that we tend to think of that's classically associated with the bulging fissure, and that is in Klebsiella pneumonia. And the classic scenario that they'll give to you is an individual with alcohol use disorder or some other kind of immunosuppression, and then they'll have a lobar pneumonia, and then you'll see the bulging fissure, and they're trying to lean you towards Klebsiella as the entity. All right, so moving away from lobar pneumonia, here's our next case. 60-year-old female with fever and cough. Let's go back to the radiograph. So whereas in the other cases, we were seeing more focal consolidation, here we have more patchy abnormalities in the bilateral lungs. So that person went on to get a CT, and it showed these findings. So the question I have for you is, where did this patient's infection begin? Did it begin in the airway mucosa, the alveolar spaces, the lymphatics, or the vasculature. All right. So in this case, this infection originated in the airway mucosa. So this is a nice imaging appearance on both radiograph and CT of what's called bronchopneumonia. So this is in distinction with lobar pneumonia, what we just saw, because this type of infection originates in the airways themselves rather than the alveolar spaces. And so whereas in lobar pneumonia, that infection would spread via the pores of Kohn, in bronchopneumonia, the infection spreads via the airways themselves, and we call that endobronchial spread. And that's the defining feature of bronchopneumonia. And just like with lobar pneumonia, the most common cause of this one is going to be bacterial etiologies. Strep pneumo and Klebsiella don't commonly cause this bronchopneumonia pattern. The bacterial entities you'll think about with this one are going to be Staph aureus, Haemophilus influenza, and Pseudomonas aeruginosa. Other things you want to think about, even though bacterial is most common, other entities that can cause this appearance are going to be mycobacterial infections such as TB and non-tuberculous mycobacteria. And then fungal can cause this pattern too, such as in patients with airway invasive aspergillosis. So what you'll see is on imaging is patchy asymmetric consolidation. So lobar pneumonia was pneumonia confined to a single lobe, and it's usually focal. In this case, this can be sort of patchy and different consolidations in different lobes, but it's usually pretty asymmetric. In addition to the patchy consolidations, you also have these small centrilobular nodules. We'll talk more in depth about those in just a bit, but that's another sign of endobronchial spread. And then because it's in the airways, you also have airway thickening, and you have usually impaction of the airways associated with this. Okay.
Yeah, you should be able to run polls now, Kyle.
Oh, nice. Okay, let me see. Oops. Let me be gentle so I don't give away the. Sorry, I'm just checking to see. Okay, it says I'm a co-host. All right, it's not
I saw
offering
you
me.
as host, so you should be able to start.
Oh, you're right.
polling.
Do you know where I might find? So usually in mine, I have a thing at the top that says polls, and I'm not seeing that on my current view.
Mine usually shows up at the bottom with the other controls.
Okay, on that control panel.
Yeah.
Interesting. Okay, I may have to do some more digging into that.
Okay.
All
If it's
right.
working for you now, maybe we don't derail it.
Yeah, that's okay. All right. So we'll keep moving. All right. So this case gave away the answer, but what is the distribution of this abnormality? So let me see. My PowerPoint's not letting me go backwards. There we go. I'm going to go back and reset a bit. Okay. So we talked about bronchopneumonia and lobar pneumonia. Now we're going to move on to patterns that involve multiple small nodules. So the question was, what is the distribution of this abnormality? And the correct answer in this case is centrilobular. So for the new R2s, whenever we talk about multiple small nodules in pulmonary imaging, we try and fit them into three common patterns. And those patterns are based on their relationship to the secondary pulmonary lobule. And the three distributions are centrilobular, perilymphatic, and random. So these are sort of three schematics of the secondary pulmonary lobule. And that's sort of the smallest functioning unit of the lung. And these are about 10 millimeters or about 1 centimeter in size. So they're quite small. And they usually have this hexagonal appearance to them. But they all have the same architecture. And that is that within the center of the secondary pulmonary lobule, you have the arteriole and the bronchiole running in the center. And then on the periphery, you have the interlobular septa that connects it with the other secondary pulmonary lobules. And within these septa run the pulmonary veins and the pulmonary lymphatics. The pulmonary lymphatics also run along the bronchovascular bundle as well. So those are located in both locations. So when we talk about these nodule patterns, a centrolobular pattern is one where the nodule is located right in the center of the lobule, and it grows out from there. So what this looks like on imaging is that they tend to spare the interlobular septa, and they spare the pleura. So there's going to be a very thin margin of subpleural sparing with this pattern. And because it's centered around the bronchovascular bundle, this indicates that the process that caused these nodules is most commonly is an airway-centric process, such as an airway infection. Very rarely you can have more of a vascular process cause these nodules, but that's far less common than an airway infection causing a centrolobular nodules. The next pattern is perilymphatic pattern. And this is basically just any sort of process that deposits nodules along the lymphatics. So these nodules are going to be anywhere you have lymphatics in the lung, along a peribronchovascular bundle here, and along the interlobular septa. And then the last pattern is a random pattern. And this is basically just the nodules are numerous and everywhere, and they completely ignore the architecture of the secondary pulmonary lobule. So they don't care whether or not they're in the center or in the periphery or sort of midway between the two. They're just completely randomly distributed. And when it comes to pulmonary infection, the only two patterns we really care about are centrolobular and random. Infections don't cause perilymphatic nodules. So we're going to step through each of those. So centrolobular nodules are far and away going to be the most important and the most common that you encounter. You're going to encounter centrolobular nodules very, very, very commonly on chest CT. Infection is a really common cause of these. And you can think of these as an early manifestation of bronchopneumonia. So again, this is an infection that is centered in the airway, and then it spreads via the airways. And as the infection progresses, these nodules will eventually coalesce and form consolidations. So then you'll get your patchy consolidation plus nodules picture of bronchopneumonia. So yeah, these are going to be just like lobar pneumonia and bronchopneumonia. Bacterial is going to be the most common cause of infectious centrolobular nodules. And again, other considerations would be mycobacterial and fungal. And then in cases when where these nodules are symmetric and bilateral, viral is also a consideration. And so usually when it's bacterial, this pattern is going to be very patchy and asymmetric, and you'll have a focus in the right upper lobe and then another cluster in the left lower lobe. But when it's viral, they'll be bilateral and symmetric. Other non-infectious considerations to this would be aspiration. So if it's early aspiration and it's just a sort of a chemical pneumonitis, you'll still have a centrolobular pattern. And basically it's just the debris that they aspirated filling the small airways. And it'll be in more of a dependent distribution, depending on how the patient was positioned when they aspirated. Another thought is if it's chronic, say that you see centrolobular nodules and they're still present 6 months to a year later, then you want to start being more suspicious that this is adenocarcinoma, which can spread also via the airways. Okay, a subset of centrolobular nodules are going to be tree and bud nodules. And this is a specific pattern that's even more specific for infection. And what this is the usual centrolobular nodules, but they demonstrate this branching pattern. And the branching pattern is thought to look very similar to in the springtime when you have trees that are in bloom and you see the early bud. And so that's why they call it tree and bud appearance. Some people also say that this pattern looks like kind of that old school kids toy of jacks, where you would like, you'd throw them on the floor, and honestly don't know how that game was played, but people think it has a similar appearance to jacks. So whatever helps you remember it. But basically what it is it's a centrolobular nodule, and the branch that connects it to the airway is impaction of the distal bronchiole. And so it's basically infectious and inflammatory debris that's causing impaction of that distal bronchiole. The infections you want to think about, again, are bacterial and mycobacterial. This is commonly seen with reactivation tuberculosis, this tree and bud nodules. And then fungal is another one that can be seen in patients who are immunocompromised. Once again, aspiration is another thing to consider if the pattern is in a nice dependent location. And the aspirated debris will be what's impacting the distal bronchiole. Okay, so next case. This is a 72-year-old female with chronic cough. Which of these is the likely causative organism? So here we have scattered centrilobular nodules. And you can see here in the right lower lobe, these are demonstrating a nice tree and bud appearance. We also have some bronchiectasis in the right middle lobe and in the lingula. So when you see this combination of findings, especially in either chronic symptoms or chronic on imaging, the thing you want to think about is a Mycobacterium avium intracellulare, or some people call it Mycobacterium avium complex, or MAC. So in this type of infection, you have patchy, chronic tree and bud nodules. There's a predilection for the right middle lobe and lingula, and then bronchiectasis is common. So we see all those findings in this case. This is classic in elderly women who are immunocompetent. And you'll hear it termed Lady Windermere syndrome. And what that means is that it's actually Lady Windermere was a literary character from the Victorian era. And she was known for being very proper and fastidious, and basically they would suppress their cough. And so that's kind of how it got its name, is it was sort of thought that women were trying to be proper and suppress their cough. And so that would lead them to develop this kind of infection. It's sort of been found that that's actually not the case, but the name has still stuck. So you may hear Lady Windermere syndrome for MAC infection. Okay, next case. So which best describes the distribution of this abnormality? So we talked about centrilobular nodules. So think about what other pattern we also mentioned that infections can be in. In this case, it's going to be random. So again, we see multiple small nodules, but what we see here is that nodules are all along the fissure here. And if I go back a few slides, it's actually, this is a good one. This is a good example to show how centrilobular nodules will spare the immediate subpleural areas. There's a little rim of black, and the nodules will never actually touch the pleural surface. But that is in distinction to this random nodules, where you do have nodules along the pleural surface, but you also have nodules everywhere else. So they're essentially all over the secondary pulmonary lobule with no regard to its architecture. And that's classic for random pulmonary nodules. So in the setting of infection, when you see random small pulmonary nodules, the thing you think about is a hematogenious spread of the infection. It's usually they're going to be very small, 1 to 2 millimeter nodules, very well defined, and they're often diffuse and homogeneous, and again, they're going to be along the pleura. So the thing to remember is that this indicates a hematogenious spread, whereas centrilobular nodules suggest an airway spread. So the entities that can cause this when it comes to infection, the most common are going to be miliary tuberculosis and miliary fungal infections. You can get miliary or random distribution of lung metastases. They can give you this appearance. And then very rarely sarcoidosis can do this, but it's not its most common imaging entity. But sometimes the nodules in sarcoid can be so numerous that they can have this appearance. But don't think of this as a sarcoid pattern. The primary things to think about are going to be miliary TB, miliary fungal, and metastases. Okay, so now we've talked about consolidation. We've talked about multiple small nodules. Within that, we talked about centrilobular nodules and random nodules. So the next pattern we want to examine is multiple large nodules. So it brings us to our next case. This is a 28-year-old male with history of IV drug use and fever. And the question is, what is the most likely mechanism of inoculation for this patient's pulmonary infection? Give you a second to think. Okay, so this is a nice case of hematogenous or septic emboli, which spread via the hematogenous route. So septic emboli, this represents embolization of infectious particles into the lungs, and the infectious source is from somewhere outside of the lung. They can be from numerous locations, but the most common tend to be from endocarditis, an infected central line, thrombophlebitis, and in periodontal disease. And the classic imaging appearance in this is going to be multiple peripheral nodules, which are at varying stages of cavitation. So you can see here that we have some that are solid and others that are cavitating, and then they're bilateral and they're predominantly peripheral. And so that's a nice look for septic emboli. And what that represents is basically these are multiple small pulmonary abscesses that are developing. Once they get deposited, once they shower off from their original site and then get deposited in the distal lung parenchyma, they'll then grow and become a pulmonary abscess. So here's our next case. 33-year-old male with fever, neck pain, swelling, and shortness of breath. What is the most likely causative organism? I've got some arrows to sort of point at the relevant abnormalities. Okay, so this is a case of Lemire syndrome, and then the causative organism for this one is Fusobacterium necrophorum. So it's not often in radiology or when it comes to pulmonary imaging that we can give a fairly specific microbiologic diagnosis based on imaging findings, and this is one of them. So they really like to ask questions on this one, and you'll have people like to when you're reading out, they like to ask questions and pimp you. So this is a good one to sort of have in the back of your head. This is caused when you have an oropharyngeal infection, such as like a retropharyngeal abscess, which this patient was on their way to developing. The infection in this region can eventually reach to where you have the jugular veins, and it can cause infection, and then you can eventually develop a thrombophlebitis in the jugular veins. And then the you'll get showering of infectious emboli from that thrombophlebitis, and then those will get deposited in the lung. And so Fusobacterium necrophorum is by far the most common entity, and it's isolated in about 80% of these patients. Okay, next case. 47-year-old male with 2-month history of cough, weight loss, and night sweats. Which organism is the most important to consider? All right, so this is just your classic case of reactivation tuberculosis. So try and just burn this into your memory. This is a really important pattern to be able to recognize, especially if you're on call and this sort of imaging pattern comes up, because it's really suggestive of reactivation tuberculosis. And even if that's not the cause, they need to treat it as if it's TB until proven otherwise. And so the patient needs to be placed into isolation so that you don't infect sort of everyone around them. So reactivation tuberculosis, this is after they've received their primary infection of the organism and it's been contained in their body. And then based on certain factors, maybe their immune system became temporarily weakened and it was enough to allow the infection to re-disseminate. It will most commonly present with this pattern. So you'll get upper lung predominant, cavitary nodules and consolidations. And you can see that here, you've got big cavitations and nodules that are predominantly in the upper lungs and posterior. And then in addition to that, you've got our tree and bud centrilobular nodules showing up again. And again, what that equals, so tree and bud central lobular nodules essentially equal endobronchial spread. And so this was the primary site of infection here. And then these nodules indicate that the bacteria then were able to spread via the airway to these new locations, more lower in the lung. So again, burn this into your memory because it's very, very important to be able to recognize. Okay, next case. 62-year-old female with 3 weeks of fever and cough. What is the most appropriate treatment in this case? Do you think it's percutaneous drainage, surgical resection, radiation, or prolonged antibiotics? So in this case, the answer is going to be prolonged antibiotics. So this is a nice case of a pulmonary abscess. And all that means is that it's a pulmonary infection that eventually underwent necrosis. And then the necrosis, the necrotic material collected and it eventually communicated with the airway. And so the patient was able to then cough up the necrotic debris. And so what's left behind is this pulmonary cavity. And oftentimes there will be an air fluid level left over. And so the air fluid level is a good indication that you may be dealing with a pulmonary abscess. The causative organisms that you want to think about with a pulmonary abscess are going to be your anaerobes, especially in the setting of aspiration. Anaerobes really like to cause tissue necrosis in the lung. And so when patients have aspiration pneumonia, it's not uncommon for them to develop little areas of necrotizing pneumonia, and then they can eventually sort of become more organized into pulmonary abscesses. Staph aureus is another classic association with pulmonary abscess. Other things like Klebsiella and Pseudomonas can do it. And then, as always, based on the upper lung predominance, if there is an upper lung predominance, mycobacterial and fungal etiologies can be considered. So here's another example of on chest radiograph where you have a nice consolidation in the upper lung, and you have a really good example of an air fluid level. And so that's a really strong indicator if the patient is showing clinical signs of infection that you're dealing with a pulmonary abscess. But because it's in the upper lungs, in addition to a bacterial abscess, you also want to raise the consideration of mycobacterial and fungal infection as well. Okay, so to sort of recap our large pulmonary nodules, usually with cavitation, the things you want to think about are going to be pulmonary abscess, which is an infection that started in the lung and caused tissue necrosis. A septic emboli, which are small pulmonary abscesses scattered throughout the lungs, but they began at a remote infectious site. Mycobacterial, especially reactivation tuberculosis, and then fungal infections also can cause lung nodules with cavitation. The main non-infectious differential you want to consider is going to be malignancy, both primary malignancy, such as squamous cell carcinoma, and pulmonary metastases, like in colorectal cancer, can sometimes give you cavitary pulmonary metastases. But usually the patient's clinical information is going to strongly push you one way or the other. And then very rarely, these aren't common at all, but there are causes of cavitary nodules. Vasculitis can cause this, such as in patients with granulomatosis with polyangiitis. And then another rare entity is called tracheobronchial papillomatosis, but these aren't worth really spending too much time on it at this stage. It's most important to recognize the most common causes of cavitary nodules. Okay, so the last of our 4 entities to talk about, or our 4 imaging patterns rather, is ground glass opacity. So next case is a 55-year-old female. She has fever, malaise, and cough. So which class of organism is the most likely etiology? Do you think this is bacterial, viral, mycobacterial, or fungal? Okay, so this is going to be a good example of viral pneumonia. And really, this imaging pattern represents a class of infections called atypical infections. There's a lot of controversy around this term atypical infections as far as what's considered atypical and what's considered sort of typical. The sort of things that people agree on is that this class of infections, they share certain clinical and radiologic features that help distinguish them from the more usual pulmonary infections that we've talked about so far. The common organisms that are included are atypical bacteria such as mycoplasma, viruses, and pneumocystis are all sort of considered in this lump of infections. So, and what helps distinguish them sort of pathologically is that, so unlike bacterial and the other infections where they tended to start either in the alveolar space and cause lobar pneumonia, or in the airways and cause bronchopneumonia, this class of infections will actually start within the wall of the airways themselves and in the peribronchiolar interstitium. So they won't be within the airways or the alveoli to begin with. And so that's what gives us predominantly this ground glass attenuation on chest CT. And then another term you may hear people use is interstitial pneumonia, and that's also referring to this class of infections. But it's basically the infection begins in the airways or in the airway wall and in the peri-airway interstitium. And so eventually these can progress if the infection sort of gets worse. You can eventually get involvement of the airway and the alveolar space. And so if it gets worse, you can eventually get nodules and consolidations like we usually see, but ground glass will still be a predominant component. And then these infections, unlike the other types of infections we talked about, which were either focal or very patchy and asymmetric, atypical infections tend to be diffuse, either diffuse or they're symmetric if they're not diffuse. So this case on the right is a good example of H1N1 pneumonia. So here, sort of in the early course of their disease, they have these upper lung predominant ground glass opacities, and they're pretty symmetric, almost identical from one side to the other. And then several days later, as their clinical condition worsened, they got re-imaged, and now we can see that the ground glass is more predominant, and they're getting some areas of consolidation that develop. And so that sort of shows us that even though there is consolidation here, the predominant abnormality is still ground glass, and it's still in a symmetric distribution. So we're going to be thinking more of an atypical infection in this case. Here's another example. So this is when sometimes atypical infections can get a bit tricky, especially viral infections, if you're catching it later on in its course. So again, in an early viral infection, it's predominantly ground glass and symmetric, but as it progresses, it can eventually cause nodules and consolidations. So this is a case of varicella pneumonia. And there's some patchy ground glass, but it's progressed to the point where now it's mostly consolidative and with nodules. And so one thing that can sort of help you know to keep atypical infection on your differential in this case is the fact that it's so symmetric. So it's unusual for either bacterial, mycobacterial, or fungal infections to be this symmetric. So that's one thing you can use to help you out if you're ever wondering, should I consider viral pneumonia in this case? Ask yourself, is ground glass the predominant abnormality, or is this really symmetric? Okay, next case. 45-year-old male with HIV. The CD4 count was about 100, and he also has hypoxemia. So he went on to get this CT. And so the question is, what is the most likely diagnosis? Do you think this is CMV pneumonitis, Kaposi sarcoma, pneumocystis pneumonia, or tuberculosis? This is a classic case of pneumocystis pneumonia. So this is a really common opportunistic infection in HIV patients, especially those whose CD4 count is less than 200. It's important to be able to recognize it because the treatment for it is a little different than other types of infection. And it's usually readily treatable if you catch it in time. So the abnormality is symmetric, it's perihilar or upper lung predominant. It's almost exclusively ground glass. It's unusual to have consolidation or nodules with pneumocystis pneumonia. And sometimes you can have what's called the crazy paving appearance, and that is where you have ground glass opacity, and then superimposed on that, you have septal thickening. And it looks like sort of crazy paving on a road. You'll see that term pop up here and there in thoracic imaging, but this is one of the entities that can cause crazy paving appearance. Another common thing that these people get are pneumatoceles. And so these are just well-defined lung cysts that develop as a result of the infection. One thing that these put the patient at risk for is pneumothorax. So these tiny pneumatoceles can rupture into the pleural space, and then it can cause a sudden large pneumothorax. Okay, next case. 66-year-old female with 3 weeks of fever, cough, and worsening shortness of breath. So she came to the ER, she got this chest radiograph, and you may be thinking like, oh, I don't see any big consolidations. I don't know, maybe there's some haziness in the lower lungs. They ended up getting a CT on this patient, and the CT showed these findings. So the question I have for you, this patient was diagnosed with COVID-19 infection, but the question is, it's a true false. In patients with suspected COVID-19 infection, imaging is an effective diagnostic tool. And the answer is false. So when it comes to COVID-19, imaging is not recommended as a screening or as a diagnostic tool. PCR test is going to be the gold standard, and it's far and away going to be better than we will be at imaging. It's just not nearly, imaging is just not nearly sensitive or specific enough to be reliable. What we use imaging for in these patients is to really assess for complications. These people get imaged a lot for pulmonary emboli because they're at a high risk for PEs. And so you'll see COVID pneumonia in the lungs, usually in the setting of a PE scan. Other things they can have are, they can also develop pneumothoraces from being on the ventilator, or they can get superimposed bacterial infections. So you'll occasionally image them to sort of better evaluate those kind of complications. But imaging in COVID-19, it should not be used as a screening or as a diagnostic tool. The typical appearance for COVID pneumonia on CT is going to be like in this case, where you have bilateral, peripheral, and basilar ground glass opacities. You'll see this pretty often, especially as the variants start to create small surges. You'll see these more and more, and this is a pretty typical pattern that you'll see with COVID. As these patients, as their clinical status worsens, if it does, they can eventually progress to ARDS and diffuse alveolar damage. And this is an example of that. This is an ICU patient with COVID ARDS, and you can see that the lungs are just diffusely opacified bilaterally. And on CT, what this looks like is just ground glass and consolidation all throughout the lungs. And so this is pretty non-specific. Lots of different entities can cause ARDS and diffuse alveolar damage. It's sort of a final common pathway for several lung insults, one of which is COVID-19. Okay, so some complications you want to think about with all types of pneumonias. One of them is going to be empyema. This is a case here on the right where you have a big sort of loculated pleural effusion. It has this kind of lentiform shape relative to the lung parenchyma. And so that's a good indication that you have a loculated pleural effusion rather than a consolidation of the lung. And then you also want to think about a pneumothorax. So people with infections, in this case, this shows a very small pneumothorax, kind of right at the apex, secondary to this infection that this person has. So how a pneumothorax develops in pneumonia is usually, you can get a bronchopleural fistula. So in all those cases of like cavitary and necrotizing pneumonia that we talked about, what can happen is those cavitations can actually rupture into the pleural space, and it'll essentially create a communication between the airway and the pleural space, which will allow for a pneumothorax. Another cause of pneumothorax and infection, like we talked about earlier, is in pneumocystis pneumonia, where they get those pneumatoceles. and those pneumatoceles can also rupture into the pleural space. So that was sort of a fast and furious overview of sort of a general approach to pulmonary infections. But again, the things you want to look at are you want to combine the patient's clinical clues, such as their immune status. Are they immunocompromised? Are they neutropenic? Or do they have a normal immune system? And you'll combine that data with the imaging pattern that we talked about, and that'll help you narrow down your differential diagnosis. And again, the 4 imaging patterns you want to try and think about when you're looking at lung infections are consolidation, multiple small nodules. And again, when it comes to infection, the ones we are going to pay attention to are centrilobular nodules, which indicate airway infection, and random nodules, which indicate hematogenous dissemination of infection. You also want to look at pulmonary multiple large nodules and think about sort of the distribution, whether or not they're upper lung predominant, because that can be associated with reactivation tuberculosis. You also want to think about septic emboli and lung abscesses in this category. And then the last one is going to be ground glass opacity, and that's going to be your atypical infections are going to be predominantly a ground glass abnormality. So again, these are the big organism types that are sort of separated by whether or not they're atypical infections or non-atypical infections, and some common things that unify them. So consolidation and solid nodules are going to be more common when it comes to the organisms on the left. And these are usually going to be focal or patchy or asymmetric versus your atypical organisms, where ground glass is going to be the predominant abnormality. You can develop consolidation and nodules later on in their disease course for atypical bacteria and viral, but ground glass should still often will remain the dominant abnormality. And then these have the distribution of they're either diffuse, and if they're not diffuse, they're at least symmetric. And that can really help you keep atypical infections in your mind, where if you see a lung infection that seems to be quite symmetric in the lung, it's a good thing to raise the suspicion that this could be an atypical infection as well. All right, so these are some really good resources that you may want to take a look at. This book on the left, this is Core Radiology. I think you guys have access to a PDF copy of this. This is a really good one, I think, especially for the R2s. When you're first sort of getting your feet wet and you want kind of a bird's eye overview of thoracic imaging, the thoracic imaging section of this book, I thought did a really good job of sort of hitting the highlights of what you want to know. When you're ready to drill down a little bit more and get a little bit more detail, I really, really like this book called Fundamentals of High Resolution Lung CT. It's a pretty small book, and it's very digestible and manageable. And it really breaks down the different patterns of lung disease, whether it's infection or any sort of pulmonary abnormality. It really helps you develop an approach to systematically organize these things in your head, because a lot of pulmonary imaging is pattern recognition. And then this book, Thoracic Imaging, this is a huge, massive book. It covers both pulmonary and cardiovascular radiology. I really just use this as like a reference source when I want to really get more detail about a certain entity. But it's nice every now and then if you want to delve deep, if you're like giving a conference or a presentation on something, this has some good detail in it. But for the most part, you can get really good info on the Core Radiology book and the Fundamentals of HRCT book. All right, thanks everyone for listening, and I will see you all in just a bit at Optimism.
Thank you.
Thank you.
Thanks, Kyle.
Yeah,
Take care.
absolutely.
Thank you.